السلام عليكم ورحمة الله وبركاته. أسعد الله مساءكم بخير. معكم دكتور ماجد. ما أدري هل في صوت الآن ولا لا؟
صوتك دكتور.
جميل، حياكم الله جميعا. Today our presentation, our talk will be about cranial examination. First of all, I would like to apologize just about Tuesday, what's happened there. Unfortunately, there was misunderstanding about the organizing for this presentation. So today we'll talk about the cranial nerves, all of them together. cranial nerves كثير من الناس يتخوفون منها أو يحسون إنها صعبة. يعني أنتم لما تشوفون الأوراق والسلايدز اللي معاكم تحسونها طويلة، يعني صفحة تقريبا، يعني البرزنتيشن بالنسبة لها.
دكتور ماجد معليش لو قاطعتك.
يتخوف من الأمر هذا كله ويحس إنها جدا صعب، لكن by practice يعني there is a say if you don't use it you're gonna lose it. إذا كانت الشغلة ما تمارسها راح تفقدها. الكرينيال نيرفز غالبا إحنا لما نسويه يعني في الكلينيك usually it doesn't take more than 5 minutes up to maybe 6 minutes is a maximum. وغالبا أقل من كذا يعني تكون as a practice. By using with time you can know which one is the most important to do, which one you will concentrate on, which one you think will get you the answer to it directly. الحاجة اللي يميز غالبا كذلك في النيورو examination rather than the others is the localization. أكثر شيء يميز في النيورو إنه by clinical examination you will know what is the lesion by itself. For example,
دكتور ماجد
if you can the visual
دكتور ماجد
by itself during the examination we can know what is exactly the problem of the patient. Is it like by is it by the optic nerve itself? Is it by the chiasma? Is it post the chiasma by itself? Is it in the temporal area or in the occipital area by itself? Only by localization or by doing that one single examination. And this we'll see it now. عفوا في أحد تكلم ولا لا؟
دكتور
طيب خلط الآن هل في صوت واضح ولا لا؟ لأن يبدو في أحد فيكم تكلم أو كان يتكلم.
واضح دكتور.
جميل. طيب.
دكتور
يعني
قبل نبدأ
نعم تفضل.
قبل نبدأ راح تقدر تبدأ التسجيل إذا سمحت.
طيب أوكي. طيب. Just to make it simple for you all, I'll just share you this picture. It's clear for you. Just to make it simple. يعني في حاجات يعني راح نشوفها كثير يعني about each nerve that we will examine and what its يعني active or what its duty. Some of them are sensory, pure sensory. Some of them are motor. Some of them are mixed. Both of them are motor and sensory. It's a combination between all of them. And the site of it. فأحيانا لما تكون عندك مثل الصورة هذه it will be easier to you for revision later on. Also while you are doing the examination. Yeah, we didn't expect all of you to be perfect during the examination from the first time, but by step you will get it. فلا تصعبوا الأمر كثير بالنسبة لكم. في another picture also about the organization, about the examination by itself. غالبا تلاقونها كثير يعني. فهنا نلاقي الترتيب of the examination. We start by the attack 3 by the nose. Then we'll go to the optic nerve of the eyes and the 3 about the movement of the eyes itself. Then we go all of them up to the habitable cell 12. وهذه another picture which will be easier to you also to do to know what is from where you will start each nerve and the name of it, and also what's its function for it. مثل الصور هذه usually you'll find it in the, if you Google it about the cranial nerve examination, you will find it, and if you do it, it will be easier to you for revision later on. الآن أنا أحب إن يكون examination إنه للأسف unfortunate to the مع التباعد الآن الكل يقدر إنه يقرأ النوتس، لكن إحنا حابين إنه تكون as as a practical. So I will open one of the videos for the clinical examination of the neuros, and you will we will stop if you have any question how to do it, how to perform it. We can stop and we'll make comment also during the examination. إذا أحد عنده تعليق ولا أي ملاحظة هذه ممكن نوقف، ممكن نتناقش عليها. ما أدري هل في صوت عندكم ولا لا الآن لما أنا أتكلم؟ طيب
الصوت مقفل.
صوتي أنا تسمعني أنا؟ لا أنا شخصيا
إيه.
لما أتكلم، لأنه ما أتوقع إنه يمكن ينقل الصوت في نفسه. It's okay. طيب. First of all, it's about the olfactory nerve. Olfactory nerve, we know its purposes for smelling by itself. So usually if you start with olfactory, you will ask the patient directly, do you have any problem about smelling? He will tell you. You can do also like a change about the question. So you can say, do you have any change in your taste? أحيانا some of them they have a problem about the smelling by itself. They will have a problem about the taste by itself. So usually, if you do the olfactory examination, you will bring something an irritant smell. Usually, they bring like also it should be like a familiar thing for the patient. فغالبا يجون مثل القهوة it's familiar for all the people. بعضهم يقول مثلا ممكن فانيليا، بس الفانيليا يمكن في all people they didn't know it. So only like a coffee you can do it, and you will close like one nose and you can make him sniff it, and also ask him, does he smell it? Does he know it? If he know it, it's good. If he doesn't know it, you think that he had a problem about it, and you compare it between two sides if he had any problem about them. But it's usually we don't do this examination. It's not always, but you should know it. This is practical. ممكن تحط مثلا peppermint نعناع مثلا، النعناع يكون غالبا familiar for the patient and they can smell it. So you can alternate between all the between the nose opening between them. الأشياء اللي ممكن تسبب insomnia, if there are any problem about like we know about the tract of the olfactory, it's below the frontal lobe. So if the patient he had a mass in the frontal lobe, it can cause a compression in the nerve by itself and can cause to insomnia for him. Plus, if they had like in Parkinson's disease, usually sometimes they lost their smelling ability to smelling. عفوا ايش تقصد بالسبتايتل دكتور فيصل؟ أعتذر فصل قبل شوي. الآن هل في صوت ولا لا؟
الذي يقدر نسمع.
فصل قبل شوي ذكر عن سبقات الشخص عشان الفيديو قصده ولا عشان شو؟ إيش تحديدا؟ طيب نكمل بالنسبة للcranial nerve examination. The second one is the optic nerve. The optic nerve, we know it has multiple function for it. يعني we can examine by the it's a pure sensory. نعم.
أنت تشغل المقطع أو تتكلم وهو ما يشتغل؟ لأن ما يشتغل عندنا هون.
لا ما شغل. أنا قاعد أتكلم.
إيه.
أتكلم. لما شغله حتى بس إنه يكون تطبيق عملي فتشوفون إيش الحاجات اللي إحنا نسويها غير مع الكلينيكال بيس. المقطع زي ما أنتم شايفين يعني مدته هذا مع الشرح 10 ل 11 دقيقة. هو في الغالب في practice way it's less than that. As we mentioned about the optic nerve, it's a pure sensory. It's يعني we examine it in the visual acuity, visual field, the reflexes about the pupillary light reflex, accommodation reflex, والcolor vision, والfundoscopy. هذول ال 5 major things that we use or to examine during for the optic nerve. الآن المقطع شغال عندكم؟
إيه نعم. تقدر تشغل اللي يقولها فيصل عشان يطلع كلامه من CC.
طيب the optic nerve, as I mentioned, there are multiple things that we will examine about them. في البداية كذلك we can expect them. يعني as you can اسمح لحظة CC حاطين لغة كان حاط لغة كوريا مو انجلش. This is the scenario chart. What we are usually نعم.
الشاشة مختفية عندي أنا.
شاشة. الآن الشاشة موجودة. الآن واضحة ولا لا دكتور؟
إلا دكتور واضح.
طيب خلينا نكبر الشاشة. During the scenario chart يعني there are many things that we will do it for the scenario chart. First you do it as usual. غالبا الحين يكون معك انت scenario chart. فأحيانا في chart small chart it can be given to you or you have it in your pocket. It's a small scenario chart البعض منهم يكتبون لك فيها مثلا you should make it like about 30 centimeters from the patient. Some of them are about 20 centimeters from the patient. هي معدة small chart for you لأنه ما حد بيكون معه scenario chart large like this في كل الكلينيك لما تكون في البراكتيكال واي. فغالبا تكون في small chart for scenario chart and they write on it يعني how many centimeters you make it above or away from the patient himself. Usually when we are doing the acuity for the patient, it's allowed the patient to use their eyeglasses. فعادي ممكن إنه يسمح له إنه يستخدم ال eyeglasses للبيشنت لأنه هذه practical way. إحنا نشوف إيش new changes about the patient for now. Not we are not examining يعني not like to see what's the defect in the يعني ما هو زي مثلا في العيادات مثلا قياس النظر نشوف كم نقص اللي عند المريض. ما يهمنا النقص اللي عند المريض كثر ما يهمنا are there any new active thing happen for the patient or for himself during his presentation. So it's allowed to use the eyeglasses when they came to the clinic, and he should close each one alone while you examine it. But visual acuity you examine each one alone, each one of the eyes by itself. But البداية نستخدم scenario chart. If he cannot see it, the acuity is not very good for him. For the patient at that time we can use اللي هو finger count. That ممكن تكون حوالي 3 متر away from the patient, and you can do the whole finger count for him. If he counts very well, that's better. If he cannot count for the hand, for him, you can be close for him until you are in front of the patient himself, about like 20 centimeters, your fingers. If he cannot count the fingers, at that time you will do like waving your hand in front of him. So if you can see the waving of the patient, يعني هنا تكون درجة أقل بالنسبة لها. If you cannot, at that time you will use the whole light perception for the patient. You will bring the torch of the light, you put it in front of the patient, and you can ask him, does he see or no? واضح الكلام ولا لا؟
الكلام واضح بس ايش اختفت مرة ثانية.
طيب. أنا شكلي بعمل شير سكرين، يمكن السكرين أفضل.
ارسل لنا رابط الدكتور ويمدينا يعني نشوفه كل واحد الحال.
نحن okay, it's okay. I will send you the الآن بالشكل هذا. هل واضح لكم الفيديو ولا لا؟ مع الصوت ولا لا؟
الحين صوتك وشاشة طالعات لنا.
نعم.
شاشة بلاك بورد الإعلانات.
شاشة البلاك بورد اللي طلعت لكم، مو شاشة الفيديو، مو طالع لكم ولا لا؟
شاشة الكمبيوتر حقي.
لا.
إلا بس ما رحت أنت للمقطع.
اوكي. من عندي هنا اني I done the sharing of the video by itself. طيب الآن أنا طلعت لكم نفس الشاشة المتصفح نفسه. واضح لكم ولا لا؟ طيب ممتاز. هذه هي زي ما ذكرنا اللي هو سلايد شارت. واحنا ذكرنا الأشياء الأخرى إذا كان المريض ما يقدر إنه يشوف أو ما يقدر إنه يطلع على أو يعد، زي ما ذكرنا there are other steps اللي هو finger counting. If you cannot, waving of the hand in front of the patient. If he cannot, you will do the torch, direct torch to the eye itself. فهذه هي احنا نعرف كم المدى أو مدى تأثر النظر بالنسبة للمريض اللي صاير معه. And again, you should examine each eye alone and compare between them, the right and the left. Then we'll do reflex. Direct will constitute an indirect. We can call it direct and indirect. Indirect is that you will put the light direct to the pupil and you will see الconstriction. احنا عارفين ان الاساس for this one it's by two nerves. الدايركت اللي هو الoptic nerve, it is sensory, it will take the light, and the reflexive constriction is by the third nerve, oculomotor. فهي اللي تعمل constriction of the eye. فالدايركت احنا نشوف ال eye by itself and we see the constriction. احنا عارفين ان it's affect also the other eye. هذه indirect. So we will look to the other eye also while he put the light on it directly, and we can see اللي هو constriction about the other eye for it. احنا ليش نحط احيانا الهاند between؟ مو دائما نستخدمها، لكن احيانا لما نستخدم اللايت غالبا انت تأتي فيه من الطرف، من الجانب from the side until to the eye by itself, and you can examine it. And you will see the constriction of the pupil by itself. احنا نحط الهاند فقط حتى انه ما ياثر اللايت، ما يكون نعرف احيانا اللايت ما يكون دقيق بالمره على البيبل، فيمكن ال other eye will reach some of the light to the other eye and it will do the constriction by itself, فيكون affected this one. في حاجة يسمونها relative afferent pupil defect. حد يعرف عنها، سمع عنها ولا لا؟
ايش هي دكتور؟
sharing of the video ما زال موجود ولا لا؟ المقطع أو الابلكيشن شكله يبدو إنه يفصل كل شوي.
لا، اختفت الشاشة.
طيب اختفت من البداية. طيب هذه اللايت اللي أنا كنت أتكلم عنها إنه بنعمل اللي هو indirect والdirect في people by itself. هذه كانت عندكم ولا لا قبل شوي وقت ما كنت أتكلم، ولا كانت مختفية؟
كانت مختفية.
طيب عموما as we mentioned before, direct pupils اللي هو light reflect. احنا ذكرنا في direct and indirect. الدايركت we will do it in the same eye and you will see the constriction in the same eye. واضح؟ indirect you will see the other eye because لأنه optic nerve it will go direct يعني it will do stimulation for both of them the same side. راح يكون عنده constriction of the patient for both of the eyes when they are doing it. فهنا الدايركت we can see the right. يعني نعيد المقطع مرة ثانية. If you see the same eye, okay, the left eye of the patient, you will see that there is a direct constriction for it because he put the light on it. The indirect, you will look to the right eye for him, the one without light, and you will see a constriction for it. هذا اللي يقصدون فيه الدايركت والindirect. في حاجة يسمونها they will do swinging of the light when they are doing the examination for the patient. حط على one eye, they will put the other eye, they will put it back to this previous eye. Usually we do this if we think that the patient had a problem in the optic nerve by itself, like an optic neuritis, for example. المشكلة كان one of the eyes, it has the optic neuritis, there is inflammation on it. It will not transfer the light or the reflex very high or very speed. فنلاقي مثلا لما if the right eye it has a problem with it, اللي يكون معاهم إنه إذا حطينا direct eye أو light on it ما يكون constriction سريع فيها، لكن إذا حطينا على other eye راح يكون أسرع في constriction. ليش؟ لأنه يأخذ ال other eye it's normal optic nerve فيها، فسرعة توصيل استجابة الإضاءة تكون سرعة عالية بالمرة، فيكون فيه في الاندايركت يكون اعلى في الاستجابه للكونستريكشن من الدايركت باي اتسلف، لانه هنا يكون فيها التهاب العين، هذه في الكونستريكشن يكون بطيء فيها، ما يكون سريع بالمره، فهذا يسمونها relative afferent pupillary defect. هل حاسين انه الشرح واضح؟ انا ما خليني بسمع لكم واضح طريقه الشرح ولا لا؟ بالطريقه هذه. طيب يعطيكم العافيه. الaccommodation as we can see انه راح تطلب من المريض انه يطالع بحاجه بعيده بعدين يطالع حاجه قريبه. انت راح تشوف الكونفرجن والكونستريكشن about the pupil، لانه pupil by itself also it will constrict، تعمل زي الفوكس. كلكم تستخدمون all of you are using الموبايل، تستخدمون الجوالات، كاميرا الجوالات لما تعمل فوكس انت على جزء معينه فتلاقي مركز عليها، بعدين تعمل فوكس على حاجه ثانيه فيسوي لها بلورينج بالنسبه لها. هذا اللي يصير بالنسبه لك في البيبل. بالنسبه لك انت هي تعمل فوكسنج، فمره تسوي مثلا على جزء بسيط على جزء بعيد. لذلك البعض من يعني تشوف مثلا لما يطالع بعيد بعدين يطالع حاجه قريبه فتلاقي السايز اوف people it's change by itself related to اللي هو الاكوموديشن. وبعدين في عندنا اللي هو الشهاره تشارت عشان الكلر ساتوريشن او فيجن. زي ما نشوف هنا الارقام يعطونك فيها الشارت بالنسبه للاشاره تشارت، وممكن نشوف المريض هل ممكن يقراها ولا لا. في حاجه ثانيه احنا كذلك نستخدمها في الاوبتيك نيرف اللي هو كلر ساتوريشن. غالبا نجيب مثلا الاحمر لانه جدا دارج وعالي، فنطلب من المريض مثلا انه يقفل، نطلب من المريض مثلا انه يقفل one of the eyes.
الشاشة اختفت بعد.
اي نعم. اول ما تختفي اعطني خبر. طيب
ايوه
ما ادري بشكل مباشر. طيب اول ما تختفي هذه الاشاره الاوبتيك نيرف. كذلك احنا تكلمنا قبل عن الاوبتيك اكيوتي، الفيلدز، كذلك الكلر ساتوريشن. فالكلر ساتوريشن او الكلر فيجن نسوي فيها الاشعارات تشارت. التشارت هذه يكون لها ارقام ونسال المريض ايش الارقام اللي نشوفها. لكن من ضمن الاشياء اللي نسويها للكلر ساتوريشن انه ناتي مثلا تب لون الاحمر مثلا، اطلب من المريض مثلا يقفل one of the eyes and he can see the saturation of this eye and compare it between the other eye، فيقارن بين العينين كلهم. غالبا المرضى اللي عندهم مثلا اوبتيك نورايتس، التهاب في عصب العين، ما تكون درجة كثافة الألوان أو ساتوريشن الألوان عالية، فيحس إنه في لون باهت بيناتهم. فهنا هذا الشيء يأكد إنه في مشكلة في العين أو في الأوبتيك نيرف يتصل. هذا الفيجوال فيلد اللي احنا نشوفه في نسأل المرضى أو نسأل المريض what is the visual field، يعني في هذا defect on it or no. طبيعتها في البداية ممكن نخلي المريض مثلا about a visual field، لما يقفل عينه نطلب منه بطلب منه أقول هل في أي جزئية من الحاجة الأشياء اللي أمامك ما تقدر تشوفها ولا لا. ليش نطلب منه بالشكل هذا؟ لأنه أحيانا يكون في جزء بسيط الديفكت، أحيانا بعضهم يكون عندهم سكتوما only in the retina itself the problem for him، ما هي related to the optic nerve or the tract until the occipital. لا يمكن يكون في الريتنا by itself he had a problem with it. That's why ممكن just a small spot he cannot see it. فأحيانا أقول هل في حاجة في وجهي ما هي واضحة، فيقول أحيانا في نقطة بسيطة ما هي a field by itself. Then you will do the examination about the visual field. As we can see, you will be in front of the patient and you will close your eye the same of the patient and you do like a finger, either like finger counting or finger movement. فأحيانا عدة طرق راح تشوفونها أنتم في الكتب أو بعض مثلا يجيب مثلا pin by itself, and you can move it from the other side until inside من كل direction. يعني we can make it as كأنها علامة الزائد، فمن كل الأطراف راح تشوف مثلا المريض من كل الزوايا، مثلا اليمين الشمال فوق وتحت كذلك. فأحيانا تحرك حاجة تقول هل أنت تشوف الحاجة تتحرك ولا، أو إنك تأتيها من الطرف إلى الأمام المريض، وتكون كذلك في المنتصف بينك وبين المريض while you're doing the examination for him، حتى compare ما تكون قريبة منك أنت أو قريبة من المريض، حتى تكون fair between you and the patient by himself. بعضهم يستخدموا figure counting، فمثلا يأشر بإصبع مثلا كم تشوف هنا، يقول لك أشوف 2 and the other side I'm seeing 3 or 4. There are multiple ways to do this examination. And always compare the right and the left for the patient. يبدو نفس الصفحة ما زالت إلى الآن تختفي لحظة شوي.
دكتور اختفت الشاشة مرة ثانية.
So this is what I meant about the visual field defect and the localization. So if it was just a small in the center that the patient he doesn't see it, this is the one about the scotoma by itself. إذا ممكن تكون one eye يسمونه ocular. If it was the same side they will call bitumoral hemorrhagia. If it was both of them the other side they will call hemorrhous hemorrhagia. ممكن تكون just one quadrantopia the side of it. فإحنا نشوف التراك بالنسبة هنا الأوبتيك نيرف. Then about the optic chiasma في the other tract, the visual tract that it's had. So based on the defect the patient he had during the examination for this one, we can know where is the localization. طبعا ما أنتم مطالبين إنكم تعرفون الأسماء أو الأشياء أو وين tract for that one, just for your knowledge about what can happen for the patient or what you will get during the examination of the patient. We'll continue the same examination. فإحنا تكلمنا عن visual optic nerve. Now we'll go about the eye movement. The eye movement is, as we can see, it's about 3 nerves. It's covering the oculomotor, ventricular, and the abductive nerve. So usually what you will do, you will stand or sit in front of the patient by himself, and you will draw like an H in front of him. تطلب من المريض دائما إنه يحرك عينه مع المريض. طبعا في one thing about اللي هو visual field. Some of the patient بس نرجع للفيجوال فيلد قبل شوي. هل في صوت الآن ولا لا؟ صوت واضح؟ تفضل. في صوت الآن؟ طيب. Okay. Just about one thing about the visual field. أحيانا بعض المرضى are not cooperative with you. Some of them are maybe comatose, or some of them they had decreased level of consciousness. فالوعي منخفض عند المرضى. لما تطلب منه إنه تقول هل تشوف من الجهة هذه أو تشوف من الجهة الأخرى, they don't يعني cooperate with you. So what you do at that time, you will come to the patient and you will do a little threatening blink for them. threatening إن كانها يسمونها تخويف مثلا المريض, فتأتي مثلا بيدك مثلا من جميع الجهات مثلا المريض, لكنها قريبا من الوجه مو من بعيد تأتي باليد, لا تخليها مثلا من الطرف, تأتي بالطرف وقريبا من العين وتحركها in front of him. At that time you will see, if he do like a blinking at that time, you know that it's the visual field is intact for him. If he doesn't blink, that means he doesn't see from that side. واضح التكنيك ولا لا؟ طيب بعدين نأتي اللي هو الأوكلوموتر أو الثيرد والفورث والسixth nerve. You will ask the patient to move his eyes while you are doing the examination for him. While you are seeing, you will see the eye movement for the patient. You will assess it. Also, you will ask the patient while you are doing this examination. You will So this is the examination. As we mentioned, while you are doing the examination about the extraocular movement for the patient, you will see his eyes. Is it moving with your hand, with fingers, or no? Are there any misalignment, or one of them are يعني looking at you or no? لأنه أحيانا if the patient they have like in sixth nerve that recently their eyes, one of them it will walk with you or move with you, the other one it will not move with you when you are doing the lateral gaze for the patient. So they will have the double vision. فأحيانا لازم نسأل المريض while we are doing this examination, does he see it clear your finger or does he have a double vision? لازم تسأل المريض إذا عندك أي ازدواجية في النظر فعلمني, عطني خبر متى تكون ازدواجية في النظر. فأحيانا إيش اللي يصير معه, لأنه one of the eyes are moving, the other is not moving. The patient here they will have two pictures. Okay, لما يكون عنده two pictures, لأنه واحدة تتحرك تعطيه صورة والother one will give him the same picture but there are misalignment for them. فبعضهم يقول they will have like beside each other or horizontal double picture for them. فهذا اللي احنا نشوفه. كذلك نشوف حاجة ثانية يسمونها النستجماس. النستجماس إنه يكون فيه like a beat of the eye while you're doing the examination for them. في physiological nystagmus like one or two beats in the lateral gaze. If you do lateral gaze for them, they will have it. This is normal sometimes, but some of them they will it will be difficult for them. بس في حاجة ثانية اللي يسمونها, هذه اللي احنا اللي سويناها قبل شوي يسمونها اللي هو pursuit movement, هي الحركة البسيطة أو smooth movement. في another examination for them like this one. اللي هو يسمونه السكاد. السكاد that you will put like one finger in front of the patient and one object away from patient in the side for him. So we will ask him if he fast gaze or fast movement, they will do it. So you will ask the patient to look to your finger directly, then to look to the object, then to look your finger. This is the saccade movement. We are doing it. في حاجة يسمونها cover test, but this is not usually it's done for them, and you will cover the eye while you are doing the examination for the other eye, then you will directly move the cover for him. بعضهم إذا ما كان عنده fixed gaze they will have a lazy eye. A lazy eye no, the eye it will not concentrate on you, it will be looking to the other side. Okay, now it's about the trigeminal nerve. It's a part of it, it's sensory, and the other one is motor. Sensory, as we know, there are three divisions of the trigeminal nerve covering the face. So some M1 is covering the forehead, and the M2 is covering the cheeks, the M3 covering the chin, and below the lips, the same side for it. فلازم when you are doing it, you'll compare between the right and the left, and also about all of the three division for it. فأحيانا ممكن نستخدم بداية fine touch for it, and then we'll do like a pinprick for examination about the trigeminal by itself. The other thing about the trigeminal, as we can see here, he will touch all the three sides, the M1, the M2, the M3, this is the M3, the mandibular branch. And the pinprick, you can use it also. And also about the motor, you will assist اللي هو muscle mastication and the jaw jerk for it, and also the corneal reflex. Have a technique that you do for the examination. Just about it's not also just a palpation examination. Also, you need to inspect for it. So you will need to examine it for an inspection to see if he had any muscle wasting at these sides for the during the examination for him. The jaw jerk reflex, just prior to that he closes it, you will touch it and do it by the hammer. If the patient he had a jaw jerk is positive, it will be he will close his teeth. The corneal reflex, usually we don't do it. If the patient is awake, usually sorry, I just noticed that. Yeah, diplopia is the double of the vision, as we mentioned before. The patient he had a problem in his muscle of the eyes, so he will have a double vision for them while they are moving. تفضل دكتورة. Anyone have any comment? Okay, so back again about the corneal reflex. So usually we don't do the corneal reflex for awake patient because it's painful and irritant for them. So, but the way that we are doing it, if you want to do, you should know how to do it. So you will bring only like a clean or sterilized cotton, okay, and you will try to do it. Touch the cornea by itself. Don't touch like the eyelid or any other area, but we consider it only the cornea by itself. And then the patient, you will see like mild like reflex about it. They will try to close their eyes. This is the corneal reflex. But as we mentioned, usually don't do it for awake patients. You will touch the periphery of the cornea by itself. And then if you don't do it from the and you bring it like from the center, because if you bring it from the in the front of the patient, might be he will do like as we mentioned about the threatening and blinking, he will close his eyes. So this is a demonstration about how to do it. Facial nerve, usually it will be started by inspection of the patient, so you will see if there are any falling down, any like uh, facial asymmetry for him, either the eyes by itself or the mouth or nasolabial. You will see if there are any asymmetry for the patient. Then you will see if there are any weakness by itself during doing the facial examination for the patient. So as we can see, you ask the patient strongly to close his eyes. You will ask him also to raise his eyebrows. You will ask him to move his mouth in many different ways. Also for the test about, you'll bring like either like salty water. You'll try to put it in the first 2/3 of the tongue to see, in many areas also to see it, is he had any uh, apologize, just 1 minute please, I will come back. just about the fascia by itself, as we can see, just to differentiate what's the difference between the upper motor neuron palsy and the lower motor neuron palsy. And this is usually would come to you in your clinic or in the ER when you see a patient. They will mix between them, between the facial palsy or the Bell's palsy, which is lower motor neuron palsy. It will affect all of the face because the innervation by the facial, it will be involved from the, as we can see in the picture here, from the tract of the facial nerve itself. So it will be covering all of the eyelid, eyebrow, closing of the eyes, and the lower side of the mouth itself. While if it was upper motor, it will be covered also from the other eye area for the forehead and for the eyes. So it will be not involved for them. This is a comparison or something that usually you face it while you are doing the rotation, maybe later on in the clinic or in the bedside in the hospital when you see the patients. So just to continue about the examination. And I have to know. So again, this is about the facial nerve. You'll ask about the patient, as we mentioned, about closing the eyes, the eyebrows. Also, you see the power of the cheeks if you close it to see if there are any asymmetry, and you can ask him also to whistle, as we can see, and moving the cheeks. So on the as we know about the vestibular by itself, it's by hearing usually, and also about the coordination. So there are multiple things. You can either come back to the patient and you will whisper few things in front for his hearing, or just you might rub your hand behind him. ممكن بس تحرك يدك behind him and you can see does he hear or no. You can compare between them, the right and the left. Then there are two tests usually we are using for the patient if he had any defect, the renal test and the Weber test. Usually we are using the tuning fork with 512 hertz. احنا غالبا التونينج فورك that we are using is 128, بس هذه غالبا تكون في الفايبريشن examination في اللمس when you are doing the limbs اللي هو 128. غالبا في الرن test we are using ال 512. فالتكنيك هنا انه to see about the bone conduction والاir conduction. غالبا air conduction is more than the bone conduction. We put the tuning fork behind the ear until the sound is حتى انه يختفي الصوت او الاحساس اللي عنده في bone conduction. If he doesn't feel, when he doesn't feel anything, we will put it in his ear. Then he will hear the sound from it. And compare also usually between the right and the left. The Weber test, he will just knock the hammer and put in the forehead, and he will compare between the right and the left. Does he have the same sensation of it or no? Well, then this is usually we don't do the same technique. Other technique about if he had any problem about the coordination or balance for the patient. Then we'll do the glossopharyngeal on the vagus. You will see the uvea, and you will see you will ask the patient to say the soft palate, is it going up or no for him? Also, you can do a whole gag reflex for the patient. Usually we don't do it because it's painful and irritant for the patient. أنا أعتذر ما أدري ليش كل شوي يفصل نفس الفيديو. لكن as we mentioned before about the gag reflex, usually don't do it for the patient because it's very irritant for them. الافferent بالنسبة للgag reflex is glossopharyngeal nerve, والefferent for it is the vagus nerve. So usually what we will do, we'll bring like a tongue depressor, we'll ask the patient to open his mouth, and you will do it in the wall of the pharynx. So you will touch it there, and you will do the stimulation, and you will see that the rising up of the soft balance and the uvula is moving when you are doing it. There are other techniques they are using it for it, but usually it's not the same thing. Either like by swallowing to see if there are any problem swallowing for the patient. Then the accessory nerve, as we know, it's a pure motor for the accessory. We'll examine the trapezius muscle and the sternocleidomastoid muscle also. And this is the technique that we are using usually. You'll ask the patient to turn his neck to the right and the left, and you'll see about the strength, about the muscle for the patient. And also, just before that, then laterally it's the hypoglossal. It's a pure motor also. It's about the muscle of the tongue. So usually what we will do for this one, you will ask the patient to open his mouth, and you will see the mouth, if there are any atrophy for him, any fasciculation, to see if there are any peripheral nerve involvement for the patient, if he had any fasciculation. And then you will ask about the moving of the tongue. Where is it deviated? Are there any deviation or no for the patient? And this is in summary. So again, about the tongue, you will see if there are any deviation about the tongue itself, and also you can ask if you are not really sure if there are any weakness for the patient. You will ask him to push his hand and the cheek, and you will see the strength about the tongue while he's doing it or moving it. So this is all of the cranial examination. I know it's unfortunate it wasn't been as I wanted because of the interruption of the video itself every time. But as I mentioned before, just to make it easier to you again, this is a summary about the cranial nerves examination. These are the nerves that you should do it or examine, and in a simple way, what you will do for them, starting from olfactory until the hypoglossal. And also here we'll see what each one that you will do usually about it. So just in summary for them, olfactory, it's about the smelling by itself. It's a pure sensory. The optic nerve, as we mentioned, that we will do 5 things for it: the visual acuity, visual fields, the color saturation, and also the accommodation and the pupillary reflex, or the light reflex that we will do for them. The third and the fourth and the sixth nerve, it's ocular motor movement. So we'll see the eye movement, where direction they will go, in all the direction. They will write like an H movement for them while we are doing it. And the trigeminal nerve, that we'll see about the sensation, about the mouth, the face, as we mentioned about the 5 sensation for it, and also the mastication and temporalis muscle movement for them that we will see inspect for the patient. Then we'll go to the facial, where we'll see about the movement of the facial. We spoke about the upper motor involvement lesion for it and lower motor involvement for it, about the facial nerve, and also it's about the taste, as we mentioned. You can use what kind of, like a salty or sour, like a lime. You can put it to see if the patient he can feel the sensation for it or no. Then we'll go to the about the hearing for the patient, and we'll do also the Weber test for the patient and running test for him. And then we'll go to the glossopharyngeal and the vagus, as we mentioned before, about the gag reflex, and also you'll ask the patient to say and you'll see the raising up of the palate, soft palate, and also you'll comment about the uvea, is it center or no. Then we'll go to the spine, the accessory muscle, where we'll see the trapezius and sternocleidomastoid movement for the muscle by itself. Then later on about the hypoglossal, we mention about the tongue movement for him. عارف إنه كان موضوع طويل شوي، لكن as we mentioned before, and I done the sharing about the picture by itself. I didn't do the sharing of the video, Dr. Abdelmajid. Any question for you guys? I hope it was clear for you all. And I wish you all the best in your career. If there are any questions, I'm very pleased to answer it. يعطيكم العافية جميعا إن شاء الله.
دكتور قبل تطلع تقدر تقفل لنا التسجيل بس؟
طيب ماشي.